The other thing that is not always emphasized is there is a need to pump prime some of the pathways to get these changes into place. And that is one of the big uncertainties. What is the investment cost necessary to save? And also, in some cases, what is the replacement cost? Because we talk about getting patients out of hospital into the community, but when you look at the evaluations, they're saying big savings in the hospital, but there's no estimate of the extra costs in the community. Even though it may be cheaper in the community, there's still a cost, and that needs to be taken into account in the planning as well. So, streams which produce fast savings which can be reinvested seem to be the ones to go for, and that's the only way in which these rather optimistic plans will ever be achieved, if there can be sufficient cash released early on. And as Nick has pointed out, in many of those work streams, there are going to be delays in achieving the major benefits, particularly those related to prevention and avoidance of long-term complications. More encouragingly, there is evidence that quality improvement comes alongside many of the efficiency-saving programs. The palliative care example was particularly strong on this, that there was a great perception of benefit to patients and their families from changing to systems which did not cost more and in many cases saved resources. So, what do we do now? If we're going to achieve these optimistic targets, we need to very quickly work out what works for us and what doesn't. So the national programme is not going to deliver for local decision makers. Work is going to have to be done in localities to work out whether the national recommendations actually work for them. You then need to formulate your own savings targets in a more realistic way so that you don't suffer from destroyed optimism. The use of innovation, particularly in things like the prevention agenda, needs to be stepped up. I think the focus on productivity is understandable and admirable in the QIP agenda, but looking at innovation may be the only salvation, and there are ideas out there which can help with step changes in the way that care is delivered. So those are three key points that we've identified, but we're interested to open up the debate about your views on, is this whole thing realistic, or is it just a pipe dream? Are there things that are being missed? Are people sitting quietly on good ideas which they know are going to save them money, but they're not letting on so that they look good when they actually do it? What are the main concerns of people out there in the service when they keep getting talked at by people on the NHS executive saying, we're relying on you to produce the 15 to 20 billion for us? Thank you very much. Please, first question down the front. I think we have microphones. If you could please say who you are and where you're from to preface your question, it would help us. Thank you.
Thank you. Yes, I'm Shirley Murgrath from Hackney, and I'm involved in various activist-type activities, you could say. Is there a reason for, are we no longer using the figure which was prevalent for a long time, which was that healthcare in the private sector costs 11% more than in the NHS, and clearly the direction of travel is into increased privatisation of healthcare. Has any account been taken of the cost impacts of low morale during a procedures of huge change and uncertainty, job loss, redundancy, and so on? Sorry, I had one other thing, but I guess two will be enough.
Okay, I won't pass those over to Nick. I'll take those. The first one, I think the defence against the private sector cost argument, whether it's 11% or whatever it is that everything will be paid at tariff. So the private sector wants to be a willing provider. They have to be willing to provide at tariff. So the cost of the NHS of private provision should be no different from that in the public sector. I think the main difference in cost between private and publicly funded systems is the level of activity and demand and thresholds at which care is delivered rather than in terms of the cost of actual procedures themselves. But we don't have so much experience of that in the UK. the morale point, of course, is crucial, because a lot of these figures that are being labelled as savings, of course, are in fact jobs lost as far as certain people are concerned. And productivity, particularly through innovation in technology, only comes through using the workforce more efficiently. And if you are wanting to deliver greater activity without greater cost, then you can't do it by employing more and more people. So there is no factor in the national calculations for the impact on productivity through people losing motivation. And that is a big worry for anybody managing an NHS organisation at the moment, how to tread the thin line between keeping people on the new agenda and keen to do things better for patients, but at the same time recognising that might have risks for themselves, and they've got to look after their own interests. And I think that's why people are talking about national agreements about salary caps, freezes, doing away with incremental drift and all that sort of thing at the moment, in the hope that keeping everybody equally badly affected will stop the necessary competition and rivalry that takes place in those situations within organisations. Yes.
Thank you. What interests me is the process of applying QIP. It could be a tick box exercise, or it could be real, and I'd like to know a bit more about the process. And it needs follow-up. For example, your interesting slide on Yorkshire about readmissions, my quick look at that chart told me that the higher percentage of readmissions was in the poorer areas of Yorkshire. So there's a real question about the effectiveness of the process, and I'd be interested in your comments. Thank you.
Yes, I think that's a very important point, because the inequality issue is still there in all the strategy documents, but there's a danger that it gets forgotten about as an equal priority to the efficiency, and in terms of its impact on the efficiency. And that slide, as I say, is a very crude comparison, which is saying perhaps there is an issue in Rotherham, but it may not be an issue that the acute trust can do anything about. But maybe it's one of the things that the new regime will actually be able to tackle in a way which is better than the old regime has been able to do. But that's a very wild assumption. If all the GP consortia are as enthusiastic and knowledgeable as our speaker this morning, then one can be optimistic. But I don't know whether that is going to be the case. But certainly that's a key thing behind will things work nationally. If they've only been tried in a few pilot sites are usually chosen because A, they're enthusiastic for the idea, and B, there's a good chance that they'll show benefit from them, as we know. So one would apply a 75% factor to their benefits, or maybe even greater, if you wanted to make a realistic estimate of that.